Cancer can affect any part of your body, soft tissue or bones. It can be relentless and surprising where it shows up. Common and uncommon types of cancer and what to do about them. Tonight, On Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. We have battled cancer since the beginnings of medicine. Our small wins were measured in short periods of extended life. But now, in some situations, we have begun to turn the corner and gain long-term victories. First, let's take a look at this week's Prairie Doc quiz question. True or false? Rectal and anal cancer are the same kind of cancer. True or false? Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We'll announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answer in. But we're answering your questions throughout the show about many forms of cancer as they're called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send us an email to the address on the screen. Joining us tonight are Doctors Mark Huber of the Avera Medical Group, Oncology and Hematology in Sioux Falls, and Ben Solomon, also with the same group. Welcome, you guys. Thank you for being here tonight.
Thanks for having us.
So let's just start about the issue of oncology. What is oncology, hematology? We'll start with you, Ben.
Well, it's a dual specialty. I often tell my patients who come in to see me a little bit of a story with that. I'm dual boarded in hematology and medical oncology, which just means I have to sit for both boards. And so I take care of patients with benign problems, non-cancerous problems, and then medical oncology problems. So you're talking about oncology specifically, this is the care of patients with cancer. But most doctors who see those kinds of patients also see non-cancerous issues just based on those training programs being kind of permanently tied together.
And your training was, you grew up here in South?
Yeah, I'm from Sioux Falls, born and raised, and kind of made a triangle around Sioux Falls, went to South Dakota State, go Jacks, and then
Go Jacks,
and then down to Omaha for medical school at Nebraska, and then I was at Mayo Clinic after that.
So the Mayo for your residency.
Mm-hmm. Yep.
And fellowship.
Correct.
Yep. Mark, you're from way the heck away from here originally, right?
Oh, right, Mississippi and Georgia originally, but for the most part, yep.
And then you did something at Hopkins?
I went to college there, and then I went to medical school back in Georgia, where I'm from, and then I also went to Mayo Clinic for residency and fellowship.
So you knew each other during your residency program?
No, Mark's way too old.
Yeah, I'm dating myself there a little bit, but yeah.
So two Mayo doctors practicing in Sioux Falls. Let's start the discussion with the question, what is the cause for cancer? I mean, I bet I hear that a lot. And a lot of people will say it's because of this terrible diet that we have, or it's like the environment is dirty and that's the cause, or there's all sorts of ideas out there. What's the truth?
It's a pretty broad answer. I mean, still one of the big ones is cigarettes and nicotine. I mean, that's probably the biggest correctable one that we have out there. There's certainly viral type infections, HPV with cervical cancers. There's certain lymphomas caused by viruses. Probably the new thing you hear is sitting is the new cigarettes. And what they mean by that is obesity, lack of physical activity is also a contributing factor to many types of cancers, a lot of the intestinal cancers in particular.
Just obesity is a risk factor. Yeah.
Yeah, there's a whole cascade of hormonal things that happen because of obesity, increased inflammation and everything, and so there's definitely an association there with several different cancer types. And there's even some association with those who've been diagnosed with a cancer, treated, and relapse risk regarding weight. So that's a. I think it's difficult to study this. Obviously it's a population-based study, and there's a lot of loose associations that happen between a certain exposure and occurrence of a cancer, and it's sometimes proving cause is a lot more difficult, and so are there environmental chemicals or other exposures? Of course, those probably play a role. Sun exposure, obviously, with skin cancers and melanoma, et cetera. But
right. Although I've heard also with vitamin D, low vitamin D, higher risk of cancer, and of course all causes of death. But we've recently discovered that replacing it with vitamin D supplement doesn't seem to change that. So is
it a cause or an effect there?
Yeah,
exactly.
What is it? Maybe it's just a marker. I do think too that if you look at obesity, there is so very little good treatment for it, because people who do gain that weight, they don't seem to be able to ever get it off permanently. But I've read recently that if you are an exerciser and you're heavy, but you're exercising, that reduces your risk from all of those causes of the problems related to obesity goes away. And so I would just say to people, whether you lose weight or not, that's not the important thing. The important thing is the exercise. Any response to that? Mark?
Well, I'd say definitely, even beyond the cancer part of it, you sleep better, you feel better. There's a lot of reasons to exercise and not necessarily just focus on the weight. And if you're building muscle mass but not losing weight, well, that's perfectly fine.
Yeah. So
I think from a cardiovascular perspective, outside of the cancer risk, there certainly is some role for weight loss as a specific goal, but oftentimes that's so difficult to achieve, as you pointed out. I think more often than not, if the weight loss is the goal, I often tell my patients that you really have to take in fewer calories than you burn, and I say it in that order because really you have control over the calories that you take in, and some control anyway, although it's difficult, right? But the exercise thing, if you exercise really hard for an hour, you may burn 600 calories, maybe 800 if you're really hitting it hard, but we're talking most of the time it's probably more like 200, 300, 400. And how long does it take you? It took you an hour to do that. How long does it take you to take in 200, 300, 400 calories? I could inhale that in about 2 seconds if I needed to, right? So that's the thing.
Yeah, I used to say a burger and fry, you have to walk 10 miles to counter a burger and fry. But I do think that there's a huge benefit from exercise, and it is a reduction in cancer risk, but to document that is really difficult. What about, I've heard there is a risk to the household chemicals in the kitchen. You know, the spray and all of the aerosols and maybe the hairspray. Do we have any data on that?
I can't quote data on it. What I do know is a lot of the studies actually that have been done show evidence of association with cancer in laboratory animals at high levels of exposure. You see so many products that have on the label known to the state of California. They're smarter than we are, but known to the state of California to cause cancer. Well, I don't know that those are always in humans. Most of the time it's actually in animal studies. There's association with Roundup. You see the ads on different herbicides, and certainly in our area of agriculture, that's some concern, and so people should should take precautions when it comes to applying insecticides or herbicides or things like that, because I don't think it's very easy to know what the risks are.
Right. Agent Orange, for example, in Vietnam. There's a lot said about that in cancer. Do you know any solid data on that?
Oh yeah, then there's a very clear list that's on the VA website where you can go and pull up what cancers are caused by Agent Orange. The big ones are lymphoma, myeloma. Those are some of the big ones. Although I think prostate cancer and some of the more common ones are there too. So it's that's a defoliant herbicide. So I think that speaks to, just like Ben said, being careful about applying chemicals and just taking appropriate precautions.
I had a patient come into the emergency room one time, and he had known lymphoma, but he was a pilot who sprayed herbicides. He was a, what do you call that?
Crop duster.
Yeah. And he said, well, and I know I did the wrong thing, but I used to pour that stuff in there, and then I reach my hand in there and stir it up with my arm, and
that'll do it.
so we've got to be careful with the chemicals that we mess with every day, and I do think inhaling chemicals is a thing to avoid. So, talking about pancreatic cancer, or thinking about pancreatic cancer, we really don't know the cause of that, do we?
For most people, you don't have a cause. Smoking has a higher risk, but most people who have it aren't smokers. I think the one thing changing, and recently on the national guidelines, the NCCN guidelines, is that everyone should have a genetic test for family causes. Somewhere along the lines of 5 or 10% can be caused by the BRCA or similar type genes. And that also
That's
is
the breast cancer gene,
exactly.
BRCA.
That's
breast
associated with breast and ovary cancer more commonly, but also like BRCA2 in particular, pancreas and prostate cancer. So I think that's one area that's really coming along just in the last couple of years.
Yeah.
Like many cancers, there is an association with smoking and pancreatic cancer, but it's weaker than some others, and probably it's multifactorial in most cases.
The colon cancer issue, we should talk about that too. There are family ties to polyps and polyposis and colon cancer. Certainly if there's cancer in your family, make sure you get the colonoscopy starting at least 50, right? But if there is a strong family history of colon cancer, that might be a real earmark for sooner than 50.
Absolutely. The guidelines, for the most part, currently still say start at age 50, but at least the American Cancer Society has actually lowered that to age 45, which isn't a major change, but there's at least one organization that has endorsed earlier screening. And we are seeing colon cancer, a slight uptick in colon cancer in younger patients. And so that's unclear, it might be dietary.
Yeah, there's a lot of younger patients, especially females, say in their 30s, and they'll get cancers out of the blue, and nobody is nationwide. It's been well described, but why? Nobody knows. You know, and just a word on Cologuard, that's a good test to help catch cancers, but really a colonoscopy is trying to catch polyps before they ever become a cancer. So it's still the best to just have a colonoscopy.
Yeah, Cologuard is a stool test, and people like the idea that they can submit a stool sample rather than doing the colonoscopy. It's a whole lot easier, and it's a good test, but it's more for average risk patients too than patients with high risk.
Yeah.
So that's important.
I think do not skip that colonoscopy at 50, and then follow up according to what they found. You know, certainly if there's family history of cancer, maybe sooner. We've got a caller from Sioux Falls who has neuropathy and is considering a stem cell injection. Have you heard that for neuropathy? A stem cell injection for neuropathy?
I don't know about peripheral neuropathy. I think they'll do it more for some of the central nerve damage lesions. I will say that neuropathy is a difficult problem with chemotherapy. Probably a third or half of our chemo drugs cause at least a little bit of neuropathy, and it's very real. It's hard to treat. Once you get it, there's really no proven treatment. So I could see why someone is trying to do something novel or new, because the standard pills are okay, but not great.
You know, as a guy who has neuropathy because of cancer drugs that you prescribed for me, I don't blame you personally, and I knew full well that the risks, and you backed off on doses as the neuropathy occurred. But it is a significant problem. That I figured this, neuropathy or dead? I think I'll take the neuropathy, and that's what I've done.
The only thing I would say to this individual who's calling in is there are, I would say, less than reputable sources to get what would be termed a stem cell injection. So I would just be sure that it's done at a site that's has a very good reputation, and maybe if it were even better if it were part of a clinical study or clinical trial, because I can tell you this is not, I don't believe, an FDA-approved therapy for neuropathy.
Yeah, I think that's a good point. There's a lot of hoo-ha out there, and we should talk about hoo-ha. And I wanted to talk about stevia and other things in our diet for causes, but we've got some questions. So I want to go to this. Well, let's do this first. Human papillomavirus, or HPV, is estimated to cause nearly 35,000 cases of cancer in men and women each year. However, there is a vaccine that can help protect against those cancers.
HPV is a virus that is very common, and there's quite a number of different types, and all of them cause different things. So there's 40 of them that affect the anogenital region, so things that we care about in our specialty. And they can cause genital warts and can also cause cancers of the area. So there are two main ones that can cause cervical cancer specifically. Those are 16 and 18. And then there's a number of other ones that have been associated with cervical cancer as well, but they are less common. HPV is very common. We have a vaccine that can help prevent the sequela of HPV infections in cervical cancer, anal cancer, head and neck cancers, and penile cancers. And so it's really important for both my patients who are females as well as male patients to work on getting this vaccine. The vaccine is one that helps our bodies recognize the virus itself and able to fight it better. So the vaccine has different pieces of the virus that don't actually infect you, but they cause your body to have a reaction to those pieces, so that when your body actually encounters those pieces of virus, when you come in contact with that virus, then you can form an immune response and kill off those viruses so that it doesn't cause any other effects. 11 through 13, and so that's when we would prefer to do it, and it's a 3-vaccine series. Once you start it, then 6 months later and 12 months later. But if there is a break in the vaccination schedule, if you don't get it at the 6 months, you don't have to restart. You can jump in where you left off. You can vaccinate up into the 40s, and especially if you're at a higher risk for getting HPV, then that would be a patient that I would recommend, even if you haven't gotten the vaccine before, to be able to get it.
Thank you, Dr. Eberle. And so, I mean, that's very interesting that we actually can prevent cancer with a vaccination. I mean, but people are reluctant about this. Have you heard that reluctance?
I think there's a general reluctance about vaccines, and that's a whole other topic with regard to children, because this vaccine is available to older age children, young adolescent children, and where the parents are still generally making medical decisions for them. So that's kind of a different topic altogether. But I look at this vaccine as like a long-term investment type vaccine.
Yeah.
It's not like the influenza vaccine, which is great. People should get their flu shots, but it's a different kind of a vaccine that it's a series of vaccines that will provide some long-term protection against the highest risk viruses for causing cancer. And Dr. Eberle mentioned cervical cancer, but also it's associated with HPV positive head and neck cancer and anal carcinoma as well. So I think that's important for people to know.
Well, some parents don't think that they need to give their children that because their kids will now be free to make love earlier than they should because of the vaccination. Mark, have you heard that story?
Yeah, you hear things like that occasionally, but really when you see patients and they go through cancer treatments and chemo and radiation for like a throat cancer driven by HPV, you say, look, if I can do anything for my kid to prevent that, easy decision, really, I think.
It should, I mean, for goodness sake, it's an easy decision. Do it. Just get it done for your kid. And I mean, you think about it, it's not only that, but it would prevent warts of all kinds. So that's an easy take for me. Let's talk about the issue of food and cancer. Some of the things that people are talking about is the risk of cancer that comes from diet pop. And I've heard that, and I've looked at it, and I've read from Consumers Report that really some of the stuff, you've got to drink a lot of diet pop before you put yourself at the risk of those rats who are drinking the equivalent of 100 cans of diet pop, and then they get a higher risk of cancer. But still, you don't want to put yourself at that risk, and you don't know what you're doing. What's your take on that, either one of you?
I've never personally seen a very strong association with diet sodas or other sort of sugar substitutes, if you will, and cancer. Not strong enough to strongly recommend that people avoid it. I think it's one of those complex associations. I mean, there's some studies that I have seen in the past that I think show that people who drink diet pop are more often obese. Okay, is it causing their obesity? Probably not. It's probably they're drinking diet pop because they think they're trying to avoid the sugar in the sugar containing soda. So if that's the case, teasing those kinds of complex exposures, obesity being one of them that we've covered already for cancer risk, out from each other and proving causation, I think is difficult.
You agree with that?
I agree with that, and I think it's everything in moderation. It's we're not going to tell you not to ever open a diet pop ever again in your life, but by the same measure, some people drink 12 a day, and you don't need to be doing that either.
Yeah, I have moved to the sweetener for my morning cereal to stevia, and Consumers Report said we don't have any data on it, of course, but it is a plant-based sweetener, and so that's what I've done. Don't know if it's the right thing or not, but that's what I've done. A caller from Alcester would like to know the difference between the conventional radiation versus proton beam radiation for prostate cancer. Do you have an answer on that one?
Well, that's actually a little bit of a complicated question right now. The regular radiation uses electron beams, and if I'm not mistaken, and then there's proton beams. They've built a number of proton beam facilities around the country. I think where they've very clearly been shown to be beneficial is for childhood cancers. For instance, treating pediatric brain tumors in very critical, sensitive locations. There really isn't any clear-cut, as of yet, proven advantage for proton over standard radiation for some of the more common cancers, but that is a little bit of a fraught area right now. You've got these big, expensive centers that have been built, and they have to treat people and promote them. It's not wrong to do. It's not, and there is certainly a reason why you're going to have less dose given to the bowel and the bladder and less side effects potentially. I can't tell you it's better, but it's not. No reason to think it's worse either.
Okay, but there's also the question of radical prostatectomy versus radiation therapy for prostate cancer. Do you have an answer for that one?
This is one of those very individualized decisions, and we have to include actually several potential modalities. Of course, there's surgery, there's external beam radiation, there's prostate brachytherapy, which is actually radioactive seeds placed into the prostate, and there's watch and wait. Watch and wait is also a potential option depending on a patient's age, their health issues, et cetera. And there's been some good studies that have been done that have shown that that's not a detriment in an appropriately selected patient.
If you're old enough.
Correct. You avoid the complications of treatment and surgery in that case. And so I think that's...
And the complications of surgery include impotence or retrograde ejaculation or...
Incontinence, urinary incontinence, several things. So I mean, I think it really, it comes down to one of those doctor-patient discussions and weighing out all the risks and benefits. And
well, then there's hormonal therapy too. I mean, we include that. So that's a real call of an oncologist, isn't it?
I think there are a lot of options that we have to sort through with people, so it's part of our job.
If you go to a radiation oncologist, she or he will say this. If you go to the surgeon, he will say this. If you go to the oncologist, it's neither one. I mean, so I kind of like to start with the oncologist on that one, or your primary care doc. That's the other. Sometimes it depends, but it all depends upon your age.
Age and health issues. I mean, you can have a young person with a lot of health issues that it's right to be conservative.
A caller from Sioux Falls asks if oral chemotherapy is effective. Oral chemotherapy, Mark.
That's becoming increasingly more common with a lot of the newer FDA approvals. In fact, we're seeing probably at least as many oral as opposed to IV chemos. Just because it's oral doesn't mean there's an intuitive thought that if you give it IV, it's somehow
gotta be better.
You get it in there quicker, and it's gonna. But that's not the case. It really doesn't correspond at all. It's a fair question. It's a good question, and it's really all about the mechanism of action, what results have been shown with the drug, and so. In summary, yes, it can be at least as effective oral therapy as opposed to IV.
So, I'm asking the oncologists this question, but there is, through the years, there's been, okay, well, that doggone chemotherapy makes my hair fall off, it makes me feel bad, I feel and it's no better than just having the cancer, and I feel miserable from the cancer therapy, and I've had more than one patient who runs from it. I don't want any chemotherapy. It hurts too much, causes so much pain and misery, more than I would have from the cancer. Now, I want both of you to respond to that comment, because there's a fear of chemotherapy out there.
I often, so there's no doubt that the drugs that we use have side effects, and there's variability from patient to patient for sure. What I often sort of tongue-in-cheek say to patients who are really reluctant to take any drug that may have side effects because they've heard about the negative effects of, say, chemotherapy or other drugs, is that the only people that write hotel and restaurant reviews tend to be the ones that had a bad meal or a bad stay. Yeah. Okay, I'm not trying to oversimplify, because there are people that definitely have side effects, and we have already kind of talked about neuropathy as one of them. But there's many other things. So it's the truth that these are real drugs with real potential risk. But that being said, a lot of people do better with these treatments than they think they're going to. And that's kind of the main message that I try to get across to people. And there's a lot of supportive care that we have that we didn't have before, too, to help them through it.
Yeah, and you're going to say a similar thing?
I would say very much that's the case. We certainly value people's past experiences. Sometimes family members had a very tough time 25 years ago, but often our drugs now are more effective, better tolerated. We have better nausea drugs, and we're seeing more and more of the immune therapy drugs, which most people who get those say, "Did you even give me anything? Did you give me sugar water?" They don't even feel it. They feel fine. They have some side effects. They're not without side effects, but it's certainly not that mental image of hair loss and vomiting that you think of with sort of old-fashioned chemo.
And the one thing I just would want to point out too, and this is maybe, I don't want to get too far into the semantics with it, but a lot of what we do, a lot of these pills that we give, I wouldn't actually, as an oncologist, call it chemotherapy. Really, to me, that we have really, in medical oncology, put radiation and surgery aside, but in medical oncology, we have a few tools. We have immunotherapy, we have chemotherapy, and then we have targeted drugs. These are drugs that have a completely different way in which they work than traditional chemotherapy. So the side effect profiles are different. Most of them are orals, and so you really can't make a broad statement about tolerance, because there's so much variability between drug to drug.
Yeah. I have to say that before my Whipple surgery for pancreatic cancer, they gave me chemo and you gave me chemo and radiation, and set that up. And the surgeon said to me, "I found that people who had less than 4 doses of this 4-drug round of chemotherapy and then the Whipple surgery had a 2-year average longevity. Those who had more than 4 had a 5-year longevity with pancreatic cancer." Because the truth is that whenever you get pancreatic cancer, likely as not, it's already spread, even if it looks like you've got it only in that one spot. And so the point I'm making is it saves lives. We have to not be afraid of it. And if your doctor is recommending it because it might make your life better or longer, or realize that chemotherapy saves lives and or improves them. So there's my blurb. All right, well, let's go here. The absolute best defense against disease is any kind, including cancer, is our own immune system. The trick is to get the immune system to recognize the invader for what it is.
Chemotherapy, when we think of it in the traditional sense, is generally medications that are toxic or chemicals are going to damage cancers directly. Immunotherapy would actually be a therapy that would try to activate or get the immune system to fight cancer. All of our treatments that we use right now, it's typically a treatment course. So you select, we're going to give so many rounds of chemotherapy or so many rounds of immunotherapy. What we've done thus far with immunotherapy is it's something that people tend to stay on, for a longer period of time. The way I describe it to patients, it's kind of like an immune booster. You come in once a month to try to get something to keep the immune system activated. I think we're still learning. Do we need to do that? We don't know yet. I think for some cancers, yes, we're going to need to do that continuously to keep it under control. Other cancers like melanoma, for instance, will treat patients now for a period of 1 or 2 years and then stop treatment if the cancer remains in remission and then just observe. So it's a little bit different than chemotherapy in that you may be able to use it for a longer duration to keep the cancer under control, whereas chemotherapy, we're often taking breaks or only able to do it for a short period of time because of the side effects. There's actually quite a bit of different types of immunotherapy right now. One type would actually be just as we were discussing in infusion. So these are proteins basically that are telling the immune system it's okay to attack a cancer. Cancers actually try to defend themselves by turning the immune system off. So our drugs that we're using right now in the clinic are actually proteins that tell the immune system it's okay and to turn back on against the cancer. One other type of immunotherapy that's been approved is actually something called CAR T cell therapy. And what that actually is actually removing immune cells from the body, taking those immune cells out and isolating those, and then actually engineering those immune cells to go back in and attack a specific target that's specific to that cancer. And in addition to that, they're actually turning on genes that activate those immune cells. One thing for patients to know about immunotherapy is I think it's very exciting. Everybody wants to access it, but right now we're at the beginning. And for many cancers, it's not something that's necessarily available or effective. And I think what I encourage all patients to ask their physician or to look around is actually to talk about clinical trials. And what clinical trials are basically saying we have this new treatment, maybe this new immunotherapy, and we think it's going to work for this cancer. And it's basically trying to get patients access to these newer treatments.
So he was talking about immunotherapy and a variety of things about immunotherapy. I mean, that's the thing that cured Jimmy Carter, for example, right? I mean, a melanoma that had metastasized to his brain and then it went away. Are we thinking that the hope for the future is going to be more and more immunotherapy?
No doubt about it. I mean, I think a lot of people feel that we've probably gotten as far as we'll go for a lot of cancers with just regular chemo that we're used to over the last 40 years or so. And clearly the frontier is immune therapy. That really seems to be where the progress is being made right now.
I've heard that if you can just dance on a lily pad long enough, the next lily pad and this lily pad, until you find someone along the line gets that cure that you can get, for example, as they're getting with melanoma.
Yeah, I mean, the drugs are well tolerated and can have some amazing results. What Dr. Powell actually alluded to, though, is that not everybody benefits. So when these big breakthroughs come through, it kind of makes it seem as though every single patient is going to get the same benefit. And I think right now, one of the big things in research in oncology is to try to sort out who is most likely to benefit and who is very unlikely and may need some additional therapies.
Yeah. So it's not the end all.
Correct.
And it's certainly a cutting edge of research, and it looks like it's growing, but. A caller from Black Hills states that her sister has leukemia and continually goes in for blood transfusions. She also had a pulmonary embolism. The sister is wondering if there's any way she will get better and if there is any hope for it. I mean, that brings to mind another patient, a friend of mine who has pancreatic cancer who presented with a little stroke and a pulmonary embolism. So there's higher risk of clotting when there's certain cancers. Am I right on that?
Definitely, that's the case. With regard to leukemia, that's a pretty broad question. There's acute and chronic different types. Certainly that sounds tough when you get to the point where you're needing a lot of blood transfusions. hard to say specifically to the caller without knowing the exact details, but
Less hope because of the fact that it's requiring transfusions.
it makes you worry a little bit.
Yeah. A Sioux Falls caller asks, do you ever encourage patients to participate in clinical trials for cancer treatment? How, as a patient, do we know when to say yes or no to clinical trial options?
I'm a big proponent of clinical trials. I think anything that we talk about here today was very likely some sort of a clinical study or trial. And the only way that we even know how to tie our shoes in medicine is by a clinical trial that was done before. And I think the thing that for patients is important to know is many of the trials that are out there are building upon prior knowledge. So when we talk about trials with patients, sometimes I think people get the perception that it's a brand new thing that nobody has any idea if it's going to be helpful. But many of the trials that are mainstream, that are available, have a lot of background data supporting benefit before they ever have come to the stage where the individual patient in question is eligible. And so I think oftentimes patients may have some misconceptions that we have to melt down because clinical trials are very important in moving the needle forward on an individual patient level, potentially, if that's the next new thing, or on a global sense for patients with cancer.
Right. A caller had retroperitoneal liposarcoma. Retroperitoneal meaning it's behind the peritoneum, the sac within the abdomen. So it's behind, like near the kidneys. And it's a liposarcoma, which means a fatty kind of a tumor, and had surgery in 2017. The tumor was in spine and kidney and had to be scraped off. The surgery went well, though the healing process took a long time. Later, she had surgery on abdomen and is having trouble getting this to heal. She has MS and diabetes. Does this explain why her healing process is taking a long time? Any thoughts about improving the healing process, Mark?
That's a tough one. If she had radiation to that area, which I suspect she probably did, then the radiation, healing within the radiation field is harder. In terms of having the diabetes, that's probably a tough one. The MS I'm not so sure about, but probably the diabetes makes it a little harder too.
So in terms of liposarcoma, is that an easier cancer to treat or not? And is it appropriate to even call it a cancer? It's not a cancer by definition, is a sarcoma.
Well, it is. I mean, it's not a carcinoma. So, you have a lot of broad classifications. Most cancers that we talk about in mainstream are carcinomas. They come from the epithelial lining or the lining of an organ. And sarcomas tend to come from other connective type tissues. As a group, they're rare. When you take each individual subgroup, it's a subgroup of a rare group, so they're uncommon. Liposarcomas have a variable behavior, and some are low grade and grow really slowly and come back slowly, and it maybe sounds a little bit like this was the case with this individual caller because it's been a couple years between the first resection and then the next surgery that I understand that underwent, but they can be more aggressive as well.
So, but I think you're right. I think that since it's been a while, she's doing okay. It's probably a slow grower.
Yeah, sounds like her mobility makes it hard for her to recover as well with the MS.
Take every day as you can. Savor every moment. Love your family. A caller from Minnesota asks, do you know of any treatment for systemic mastocytosis? There's a good one.
We said we were going to talk about rare stuff today, so now we've got two in a row here.
That makes sarcomas look common.
Yes, right, exactly.
It's, I would have to look it up. There's certain mutations that can sometimes. There's a drug called imatinib that's used that can target those, I believe. I think interferons have been used, cladribine and those category of drugs. Those are rare as hen's teeth, I guess you could say. And off the top of my head, it's been a few years since I last saw one.
Mastocytosis. So it's a bone marrow.
It's a blood and bone marrow cancer of like your allergy cells, the cells that make the allergic histamine.
It's a very complicated disease because you can have mast cell problems associated with different leukemias, and the classification even of that set of diseases is difficult.
A caller from Sioux Falls who asked, what are some preventive actions that can be taken to prevent cancer? Well, we talked about HPV vaccine. That's one real preventive thing. Mark, do you have any preventive suggestions?
Fortunately, the smoking rate's going down in the United States, and that's still the single biggest thing you can do to really help your cancer risk as well as your overall health. There's 101 reasons to not smoke, and that's still the big one. And we certainly have talked about weight and exercise, and those would be the next two. You can't change your genes, so you know, those are the things you can focus on.
Yeah, smoking rates are still, in our area of the country, still much higher than we'd like to see. But that being said, there has been throughout the country a decrease in smoking rates, and that has been associated from an epidemiologic, a global perspective in this country anyway, a slight decline in lung cancer rates. Other things we talked about, you know, exercise and dietary things, and to try to lose weight. You know, one thing I think that is important, we talked about colonoscopy screening. Well, there is some data to suggest that colonoscopies actually do sort of prevent cancers by finding a polyp that was going to turn into a cancer, snagging it off of the colon while that polyp is now gone, and there is some data to suggest that is the case as well. So some of these screening things can also help to prevent
polypectomies, breast cancer monitoring with mammography. You guys are fans of mammography?
Of course.
Absolutely.
So. Any other major screening things? You know, one other thing to talk about preventive, besides before we talk about screening, looking at overall mortality, overall death rate. You know, they say eat less calories, whether you lose weight or not. It's just less calories. It's this regular exercise program. It's really important. And the third and fourth things that make people live longer, and maybe we haven't proven cancers yet, but it has to do with connectedness with people. I think we underrate the value of being connected to people, and that spiritual component of knowing and caring for someone else and helping them and sensing their humanity. That's that church thing that helps us as we go through life, whether it be whatever religion it is that you belong to.
I would agree with that. Yeah, you know, and as it relates to cancer, one of the toughest, some of the toughest cases that we have to try to help people with is when they have a complex medical situation but are socially disconnected. So obviously, there's a lot of people that's not really under their control and because of their life circumstances. But really, developing those close-knit family relationships is important. Yeah.
Quickly, we got 5 questions and not much time. Do different age people have a greater chance of developing certain types of cancer? Caller asked, if I'm facing chemo and radiation, how can I preserve my fertility? Or can I, for example?
Well, those are great questions. Certainly for younger age, say younger adults, things like testicular cancer and Hodgkin's lymphoma are much more common. Things like prostate cancer are much more common as you get older. There's definitely fairly big changes with regards to as you age and what cancers you may get. The second question about fertility is actually it's pretty easy for males to do fertility preservation, and that really should be done before chemo starting.
So you store your sperm?
That's exactly it. It's a little harder for females. There's several different techniques.
Egg storage.
Egg storage and retrieval, and whether you take Lupron shots, say, but certainly meeting with a reproductive endocrinologist is most appropriate.
Yep. So retaining fertility, saving some eggs, saving some sperm for a later date when and if you decide after your chemo. After the short break, please stay tuned for the important takeaway messages from our guests, as well as the answers to tonight's Prairie Doc quiz question.
Without blood, we're, well, dead. That makes the way that blood moves in your body very important. Vascular disease, blood vessel disease, and the problems it can cause. Next time, On Call with the Prairie Doc.
Hello to all. I am Dr. Tom Luzier, a practicing allergist in Aberdeen, South Dakota. Born in Kansas, I embraced the diversity of South Dakota. This diversity comes with a price: limited healthcare resources and information. The Healing Words Foundation, through Prairie Doc, provides an open, online, interactive, public broadcasting format for reliable health information. As a member of the Healing Words Foundation Board, I am asking you please to join me in support of this work, which is funded entirely by donations from you. Please consider making a personal or corporate gift to Healing Words Foundation, a 501c3. Go to prairiedoc.org and click on the donate button and make a valuable contribution. Thank you.
So, all right, can patients who've had a transplant and are immunosuppressed receive immunotherapy?
I would say yes in some cases. In fact, CAR T-cell therapy, which is a very hot topic in immunotherapy, is exactly directed at these specific patients. But that's a very specific therapy and very specific question.
So the answer is yes. Caller from Arlington just diagnosed with prostate cancer and had a new cryotherapy liquefied gas to freeze prostate, wondering about the overall effect of the procedure and the technique. Mark?
It's a newer technique. Some of the ablations that you can do, we generally think more about surgeries or radiation, but if you have prior radiation, say, maybe that's the only technique available. There's not huge numbers for it, but if the disease is localized, it can be very effective.
Okay. What are the long-term effects of Lupron hormonal therapy for prostate cancer?
Weight gain, bone density loss. There is some association with depression. One thing that we're having to talk to patients a little bit about, that comes up now, has been some publications about association with dementia as well. Hopefully that's a longer-term use and not short-term usage. But
okay. So and you lose your sex. I mean, Lupron will just take that out.
Generally, it causes erectile dysfunction as well.
Right. What is a Whipple surgery and who is a candidate for it, Mark?
That's a surgery you perform for tumors in the head of the pancreas or sometimes in the upper part of the small intestine. It has to do with the blood flow to the area, so you have to remove the upper part of small intestine, head of pancreas, some of the bile duct. It's a big operation. It's 6 to 8 hours. It's generally done for tumors in that area, and it's certainly not done lightly. It's not just taking out a gallbladder or something much simpler.
Okay. So we've got 30 seconds, take-home message from you and a take-home message from you.
Cancer care is changing very rapidly. I encourage patients to have good conversations with their doctors because they will likely have multiple options for their treatment.
Mark?
I would say anything that you can do to prevent a cancer, the things we talked about are certainly the best things you can do. Keep your weight down, stay active, don't smoke, get the appropriate vaccines, and get things checked out if you feel something's wrong.
Thank you both. And now for the winner of tonight's Prairie Doc quiz question. True or false? Rectal and anal cancer are the same kind of cancer? True or false? False. And the answer is they are quite different cancers. They are treated differently. Surgery is generally required to cure rectal cancer, but not anal cancer. It was Nancy from Webster who answered the question correctly. Thank you, Nancy, for participating, and a book will be in the mail to you soon. We'll be right back after this.
Extra, extra, read the Prairie Doc Perspectives weekly column in your local newspaper. More than 100 newspapers in the region print the newspaper column written by Dr. Rick Holm, covering a variety of medical and health-related topics. Ask your local paper if they carry the Prairie Doc Perspectives.
In 40 years of practice, I have seen how the final moments of one's life can be inspiring or agonizing, no matter the manner of death. As I see it, the fear of death is a greater enemy than death itself. This has brought me to make the following recommendations for approaching our final moments. Be prepared. Scientific advances, along with healthcare providers' driven desire to save lives, have wrought life-saving techniques that sometimes cause suffering an unintended consequence. To correct this, making an advance directive or living will can help prevent great suffering. Going without is like arriving at the airport with no plans as to where you're going. Remember, a written advance directive is only a tool to encourage discussions about end-of-life expectations. Please speak to your family members about your wishes in the case you would later lose your memory and ability to know your family. In that situation, do you want antibiotics, IV fluids, feeding tubes, resuscitation? I don't. Also, there's been a growing emphasis and payment for hospice and palliative or comfort care. Why not welcome these added financial benefits from Medicare and insurance if you or your family qualify? These you control and can be stopped at any time. Comfort care brings less emphasis on intervention, which might cause suffering. Comfort care can be a blessing when death is imminent. Talk to your doctor and family about your choices. Dehydration can be your friend. When a person has a terminal condition, is no longer wanting or able to take oral fluids or feedings, I see it as cruel to force artificial fluids through IV or feeding tube means. Without fluids, the patient's internal pain relievers or endorphins turn on while setting the stage for living only about 10 more days. Dehydration does not cause suffering. Considering the prolonged suffering that can result from artificial fluids, dehydration can be our friend. Reconciliation brings harmony. As we get closer to our own time of death, it's prudent to say to those who matter this wisdom phrase originating from Hawaii called Ho'oponopono and made popular by Dr. Ira Byock. I am thankful for you, forgive me, I forgive you, and I love you. This can help restore harmony with others and with oneself. Bottom line, the fear of death can keep us from making important plans for an advance directive and hospice, can trap us on a feeding tube, and can keep us from finding harmony with the ones we love. A good death requires courage to be prepared. Well, a big thank you to our guests, Mark and Ben, for volunteering to come to our studio in the Yeager Hall on the campus of South Dakota State University and add their experience and knowledge to our discussion tonight. If you'd like more information about this program or to see more episodes, please like and follow us on Facebook or visit us at prairiedoc.org. Sadly, we are getting to the end of summer, but until we get a hard freeze, there is the threat of mosquitoes and West Nile virus. Please use caution when outside, especially between dusk and dawn. And even with that warning, it really isn't too early to get your flu shot. It's important not just for you, but to help protect those around you. Well, that does it for tonight from all of us here at On Call with the Prairie Doc. Until next time, stay healthy out there, people.
By.
Avera is a proud sponsor of On Call with the Prairie Doc on South Dakota Public Broadcasting. Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota.
And with the ongoing support of these individuals and institutions.
Brookings Health System.
Ophthalmology Limited,
Avera Heart Hospital,
Dakota Allergy and Asthma,
Fishback Financial Corporation,
Vance Thompson Vision,
Urology Specialists,
Brown Clinic,
American Academy of Family Physicians Foundation and South Dakota Academy of Family Physicians,
Black Hills Medical Society,
Aberdeen District Medical Society,
the Brookings-Madison District Medical Society,
Sioux Falls District Medical Society,
Dakota Bank,
Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
Aberdeen Asthma and Allergy,
and Swiftel Communications.